Hi, my name is Clyde Yancy. I'm here at AHA 2019, and I am joined by good friends and colleagues, Dr. Ileana Piña from Wayne State in Detroit, and my dear friend, Dr. Lynne Stevenson from Vanderbilt in Nashville. We are just completing a brilliant set of experiences. That is, we were able to audition incredibly important information in the broad space of heart failure, and we're delighted as a part of AHA Science News to bring that to you today. Let's begin. I think what was remarkable is how we started the session. We started the session thinking about congenital heart disease in teenagers, a patient population we thought we could never study. But we saw relevant information, and whether or not it informs practice, that's a different conversation. But the fact that we're able to get data, real evidence, I thought was striking.
I had to give the investigators from CHOP a lot of credit because every site may have a handful of patients with Fontan, but they managed to get quite a group of patients, and in North Korea, to include North Korea, and they completed it, they finished it.
Exactly.
I think it's particularly exciting because now with 1.3 million adults with congenital heart disease, hopefully we can start seeing this move into their space as well, so we can really have a new basis of evidence for dealing with survivors of congenital heart disease.
And Lynn, I completely agree with you because in most centers, the de facto physician of record when adult congenital heart disease shows up is one of us.
It is one of us.
And so it really needed to be in our session. But I love that you said the word new because that's a wonderful segue to what really is new. I think we're on the precipice of quadruple therapy for heart failure.
Yes.
Think about this, Lynn. You and I have seen this progression from DIG and ACE inhibitors to, golly gee whiz, quadruple therapy. What are your broad thoughts about this?
I'm really excited to have these tools, but I'm also very sobered because it's going to be a new time. We're no longer just going to stack every therapy for every patient. We now have to begin thinking in very different ways about how to personalize our selection of these therapies. And frankly, we don't yet have enough information to help us do that.
So Ileana, tell us what we're talking about is dapagliflozin, just as a candidate of the new sodium glucose co-transporter 2 inhibitor. Tell us a little bit about what we learned about that treatment paradigm.
I'll tell you, I was blown away when this was presented at the ESC and I saw these curves that were separating early. I mean, we often see heart failure curves separate after 6 months or even after a year, like in the defibrillator trials. They split apart very early, and with it, the quality of life, the KCCQ went up, and it stayed up. So an amazing thing, and that's a once-a-day drug. What I don't know is, when am I going to start it? And should we be doing this, or should the primary care? Are we going to become diabetologists?
But remember, what's most striking about the data set is that the benefit is there regardless of the absence or presence of diabetes.
That's exactly right.
So I don't know how we can avoid doing it, but I agree with Lynn. The intricacies now of constructing medical regimens, just the pragmatic challenges of who in the office, who in the team is responsible for titrating these therapies, how do patients access these therapies, what's the patient education burden for multiple therapies? I really do think we have to consider maybe even another entity within the disease management team that carries forward with that responsibility.
And we have to wait for other trials that need to confirm this, obviously. The one encouraging thing is everything else we do, we up-titrate. And we're not very happy with how it's being done in the community. But this is once a day, one dose. Very different. Very
different, but we don't want to overlook the expense. We'll get back to that. But while we're talking about new things, an old friend became new again, looking at the RNA compound, because now there's new data about the RNA compound. Talk to us about the new data we saw, Lynn.
Well, the new data we saw really raises this issue of how far can we extend the RNA into people who have just a slight reduction in systolic function, and to what degree does a history of hospitalization identify people who may benefit in this range that is not classified as heart failure reduced ejection fraction that we're so used to. One of the interesting things now is that I think we may end up with different groups of patients, some of whom benefit from just a decrease in hospitalization, others who may derive a mortality benefit, but I'm curious because it may not be that all patients get all benefits.
So think about how long we have calibrated the history, the definition of heart failure based on an ejection fraction, a number. boy, don't you think it's time for us to revisit that?
We've been told many times by very good investigators to quit just looking at the ejection fraction. How often do you look at an echo and you say, is it 40? Is it 45? Is it 43? And we keep wanting that number. I'm not sure we know what to do with the number anymore.
What are your thoughts, Lynne? You've given a lot of thought to this, I'm
Well,
sure.
I think that we may need to look at some of the physiology. Is this someone who's hospitalized frequently with severe symptoms, or is this someone in whom I'm primarily treating them to decrease their risk of disease progression? And even though these therapies may do all of that, they may do it to a different degree, and we may add them up in different recipes, depending on what we're targeting.
So I wonder if we do what our friends in the prevention world are doing. The entity is heart failure.
Right.
And then we look at how do we risk reclassify that condition and use the ejection fraction just as another data point, particularly since we see benefits that may be linear up to some new number, and we have to continue to work with that.
And I think it takes us back to, we really don't know HFpEF. We keep talking about it, but there's so many phenotypes that are probably in there that I think we need to get our act together as a community and come down with some phenotypes. Maybe some phenotypes benefit more than others. And you have to look at the trials and what was excluded. What type of patients were excluded in the trials, which becomes very important.
I think we got a little bit complacent with heart failure with reduced ejection fraction, because we had this group of therapies that seemed to benefit pretty consistently all the way across. I don't think we're going to find that again as
And
we
we're
move
tested
up into
in
HFpEF.
very specific numbers. I mean, we were told less than 35, less than 40. We never knew what was in between.
So there was one more point that all of us took in with a lot of hesitancy. And I think it's worthwhile that the three of us address this. Even the investigators said, we saw a signal, maybe a play of chance, that calls out women perhaps as receiving unique benefit. I think it raises a hypothesis, but none of us believe that this is an operational entity.
No,
Not at all.
with great caution.
Great caution.
I think that there may be specific diagnoses or specific pathophysiology that is more common perhaps in women, and that we're picking up that signal. But by no means do I think we have a therapy we would give to women and not to men.
This is not ready for
No,
prime time.
this is
Definitely
not what
not.
we have.
I'm really pleased that my colleagues and I have had the opportunity to share with you the important lessons learned and the new questions raised in the session with which we provided commentary. Let me summarize what we think is the takeaway theme here. This is another chapter in heart failure, a new chapter, if you will, that is characterized by now quadruple therapy with a strong evidence base appropriate for patients with symptomatic heart failure with the capability of substantially changing that natural history. We should not overlook this moment in time. We also recognize that as we see quadruple therapy, we also appreciate the complexity of implementation. As much as we all embrace discovery science, going forward we have to study process, we have to study implementation science, we have to find a way to make these drugs and these treatment strategies available to the everyday patient. We must also keep in mind one other thing. You can sense our enthusiasm. We are senior leaders in heart failure. We're so excited that we have new choices and that we can help patients with this condition. But we're sobered because we understand that with new therapies comes a cost. And all of us, all stakeholders, have to work collaboratively so we can find a way to get those therapies to patients. In the meantime, let's not forget that we can prevent heart failure. Let's not forget that we have available therapies, many of which are generic, and if we use them wisely, we can still substantially change the natural history of this condition. Ileana, let me turn to you for a closing statement, and then we'll get a closing statement from Lynne.
You know, I think after looking at registries this year, most of us in the heart failure world are disappointed that after all these years, we're still not doing a good job with the drugs that we do have that are available, and some at a better cost. And so I think we need to do better with what we have. We have to keep moving.
It reminds me of your brown bag experiment.
That's
That
right.
was wonderful.
My brown bag.
And Lynne, your closing thought.
Well, we need to remember there are 6.3 million people in the U.S. with heart failure. There are fewer than 1,200 certified heart failure specialists. We need to help figure this out, but in fact, it's together that we're going to address this condition. It's going to be general cardiologists, general practitioners, family practitioners. We're going to have to work together to figure out the best way to help all of these patients.
So there you go, new science, new therapies, new challenges, and a new workforce. Delighted that you joined in with us at AHA Science News. It's been a brilliant scientific session. Thank you very much for your attention.